So I welcome you all in this session, and I want to thank APCRS for joining us in our national conference, and it gives great value to our conference. And all the members of our society look forward to any conference of APCRS because this gives us a lot of teaching material. And this collaboration between our society and APCRS will take this relationship further forward. And we are looking forward to a great conference and a great session. Now, Ronald Leo, I'm handing over to you to moderate the session, please.
Thank you very much. I need you to stop sharing your screen so I can, yeah. Let me just share my screen. Good evening, everyone.
Evening.
Can you see my screen now?
Yes.
Yeah.
Well, first of all, I'd like to welcome all of you to this third in the series of APACRS webinars. And this one is special because we are joining the Bangladesh Society, the BSCRS, for the annual meeting for the first time. And this is a benefit of our relationship with the Bangladesh Society, sort of our member. But before we go into the program proper, I would just like to say a word of acknowledgement to the Alcon Experience Academy, who have very kindly sponsored this session for the APACRS. Those of you who don't know, the AEA or Alcon Experience Academy is a free educational resource for eye care professionals, and it contains many training and education video content, non-commercial, covering a wide range of topics of interest. You can think of it as like the TikTok of cataract refractive surgery, little 3-minute, 5-minute clips of videos, and created really by people from all across the world for all of us. And you can see some of the speakers here tonight by Shali, Anapong. They're all sort of thought leaders, and their content is tailored to the Asia Pacific. So again, thank you very much to Alcon for their support of this tonight's educational activity. So coming on to our program, now many of you will have joined our APACRS programming in the past, either at the annual meeting or at the past 2 webinars. And we thought we'd do this one a little bit differently. Now in the past, you've seen this kind of the more established figures like Graham, Abe, myself around all the time. But this time we thought we would want to really give a podium, give a stage to the younger next generation of cataract and refractive leaders. So I think will lead us into the next decade. So together with our hosts, Dr. Islam and Dr. Chowdhury, Graham, Abe, and myself, we will moderate the session. But we have got 8 of the newest, youngest cataract refractive surgeons from India, Malaysia, Singapore, Korea, Thailand, and of course your very own Ishtiaq Anwar from Bangladesh. So what we'll do is we'll let each speaker speak for about 10 minutes. We'll have a minute or 2 of discussion, and at the end we'll have a panel discussion. Now please put your questions on the Q&A tab from the platform that you're viewing on, and not the chat, on the question and answer, and I'll try and get through as many of the questions as we can at the end. So let me invite Vaishali Vasavada from India to talk to us on really how do we function in this COVID era. Vaishali, away you go.
A very good evening to all listeners, and it's my privilege to be presenting here on airflow and aerosol management in the new COVID era as a practicing ophthalmic surgeon. I have no financial interest in this presentation. I think as we resume our practices, our major concerns are that during phaco and excimer laser surgery, there is generation of aerosols. So how do we sort of protect ourselves from possible contamination through these aerosols? Similarly, in the outpatient clinic, when we are working at close distances with the patient, how do we safeguard not only ourselves, but also our staff from the exhaled airflow as a source of contamination? Well, as far as the aerosol goes, there have been experimental studies from across the world, and they all do seem to show 2 things. One, in modern phacoemulsification, there is not much aerosol generation and propagation, both with torsional and longitudinal ultrasound, and that repeatedly instilling HPMC or methyl cellulose on the incision does dampen whatever little spray is generated. We published a series of experiments, and what came as a sort of awakening reminder to us is that, as with always, basics and paying attention to details of technique will go a long way in reducing droplet propagation. So in our setup, we used a BSS stain with fluorescein, and on GO ties we performed surgeries. A digital SLR recorded all the videos, and there was a white background, as you can see, surrounding the eye, which will capture any fluorescein droplets that are being sprayed around. Now, as you can see in this video, the phaco probe is being deliberately moved in and out of the incision. But also notice that it is very well centered within the sleeve. There is no distortion of the sleeve at any point, and therefore you do not see any visible fluid droplet spray. So one very important point here. In the next video, now as you can see here, you see these profusely spraying droplets, but what we should also notice is that the phaco sleeve, the red sleeve, is being compressed between the phaco tip and the lateral wall of the incision. So that is when you will see a visible flow of droplets because of sleeve compression, and you can see that they are going in all directions, particularly upward towards the surgeon. So the same thing you see here, and every time you instill methyl cellulose, everything quietens up and there is a dampening of the upward propagation of these droplets. So I think what we did learn is that pay meticulous attention to your technique, particularly at the incision. Avoid distortion of the phaco sleeve between the tip and the lateral wall. This would be more relevant in smaller, tighter configurations that you have to pay attention, look at your incision, and that repeatedly instilling methyl cellulose on the incision will dampen any droplets or aerosol that is generated. So I think safely we can perform phaco surgeries today and onwards. Refractive surgery and plumes, what do we do with that? Well, I do agree that microkeratomes can generate aerosol, and I feel that using closed systems such as femtosecond, both LASIK and SMILE, where the patient eye is docked, may be a better idea. Also, when we talk about the plumes that are generated during excimer ablation, well, this is generally plasma, that is ablated tissue. So whether there is any viable COVID virus, nobody knows. There's not much evidence. But a plume evacuator will definitely help in reducing the propagation of these plumes towards surgeons. I think based on our experiments, our experience, and the literature available, it is safe to say that both cataract and refractive surgery can be performed with all due precautions without worrying much about the aerosol or the procedure-generated contamination. The other more important issue in my mind is how to manage the airflow both in the OT and in the OPD. And for this, we use the Schlerin imaging technique, which is used in many fields of science by engineers as well. Here, there is basically a telescopic mirror, a point source LED light, and a capturing camera. Using this imaging technique, we, for the first time, applied it in a real-time dynamic ophthalmic practice and studied exhaled airflow patterns as well as the impact of room air circulation on these. This is in the OT where the patient is made to lie within the area of the mirror, and this is what the setup looked like. And this is what the setup looked like in the OPD, where the patient's chair is within the area of the telescopic mirror recording. Now, we asked healthy patients attending both OPD and OR to participate in these experiments. Basically, we wanted to look at effect of mechanical barriers and the effect of the room air circulation. So just to orient you all, you can see here that when the patient is breathing and talking without a mask, there is a free flow of exhaled air. And obviously, this would only propagate towards the surgeon or the examiner. Now, when you put on a mask, in this case an N95 mask, both when the patient is talking and simulating a cough, there is drastic dampening of the amount of airflow and its propagation. Now, whether this would contain any COVID virus, viable virus, that also is another point to be pondered upon. The other thing that sort of opened our eyes is that a loosely fitted mask, particularly at the nasal bridge, allows free flow of air from the upper border. Taping the mask helps us to reduce any propagation of these plumes, as you see on the left image, as compared to on the right side, where the red arrow points out free flow of air leakage through a loosely fitted mask. And I think this is very common for all our patients in OPD and in OT to have a very loosely dangling mask at their nose. So please feel free to take their consent and tape it when they are in your premises. The other very useful barrier would be a breastplate or a face shield, which, as you can see on the left side, the airflow generated does not reach the right side. That is, it cannot percolate beyond these mechanical face shields. So please use them for all your staff and on slit lamps as breastplates. Going to the operating room, the same setup, you can see that when the patient is not wearing a mask, the airflow is propagating upwards, naturally towards the surgeon and the assistants. Now, putting on a mask again drastically dampens these upward going airflow plumes. So please put on a surgical mask and tape it. As you can see here in this lying down image, a loose fit at the nose area does lead to upward leakage of air through the mask. So I think what we would recommend is use an N95, and if not a surgical mask for all healthcare providers and patients, please tape it and use mechanical barriers. What I want to discuss last but not the least is the role of a forceful draft of air, which we all neglect. Now in this video, when the patient is breathing, you can see the exhaled airflow. Now is the time when the overhead ceiling air conditioner is turned on, and look at that forceful draft pushing away all the exhaled airflow downwards. So at least it's not going towards your breathing area, and you are probably safeguarded. The same thing, an overhead laminar airflow is turned on in the operating room, and with the mask, whatever little air was leaking is forcibly pushed backwards and downwards away from your breathing field and your assistant's breathing field. So I think what really came out as a startler to us is that we are neglecting the role of our circulating air. If possible, use an overhead air conditioning in both OT and OPD. If not, all of us can at least put a table fan in a direction so that the draft of air is facing the patient's face. So I think use airflow circulation to your advantage along with all the barrier protections. And we all hope and pray to God that we will sail through this COVID pandemic hale and hearty. Thank you very much.
Well, thank you very much, Vaishali. I think that was an absolutely brilliant talk, and I have so many questions to ask you. First question is, are you saying we should be operating through 2.75 millimeter phaco incision instead of, say, our standard 2.2?
I would agree that the smaller the incision, there are more chances of incision distortion or sleeve compression. But I wouldn't go as far as saying that you should use a larger incision. Whatever you do, pay attention at, rather than being focused in the center, pay attention at your incision as well as keep looking what is happening. So if you are in the center, yes. But if you are not comfortable with a small incision, 2.4 and below, this is not the time to get started.
This is a point where, many students always push against the side of the incision when they're doing surgery, when they're inexperienced. So I think there's a lesson in that, stay in the middle and not push against the incision, isn't it? Next question, do you think it's overkill? I mean, your patient is masked, you are masked up when you're doing surgery. And if your mask tests show that it's protecting us, then do we need to bother about this air conditioning flow and, et cetera, et cetera?
I think, yes, if everybody is adequately masked and protected, maybe you don't worry as much. But again, this is important because not everywhere in the world you have the same kind of rigidity in implementing these protocols. So what kind, whether it's a cloth mask or a surgical mask, and how well it is draped. Even if your drape is loose around your nose, this air can always leak up. So,
and as you say, the taping is very important.
Exactly. So it's just to highlight to us that please don't give up your enthusiasm. We all started out very well, but it's a long road even now. So depending on where you practice, please be very fastidious about these protocols.
The last point I want to raise up is you're talking about the fan blowing towards the patient. If the patients knew that, they might say, why do you blow it towards yourself, doctor? I mean, why am I more dangerous to you than you to me?
I think when I say towards the patient, you may not hit the patient in their face, but at least in an oblique manner. And I think if you talk to the patient before they enter your room, if your staff has primed them that this is for mutual safety, I think most patients would agree because they are equally scared of it as well.
Absolutely. Graham, do you have a comment to make on Vaishali's lovely presentation? Graham, are you there? Graham's not there? Babe. You must have a comment on
I
your
think this
daughter's
is,
lovely
I don't
work.
need to comment on the wonderful work Shambharesh and Vaishali did. These are the two who really did all this
It's
experiment.
amazing. It's amazing work.
It's something which is not in the capability of an average ophthalmologist, but Shambharesh, Vaishali have this mindset. And they did all this.
I've never seen anything like that.
They acquired all the setup, they bought it, and they did it on so many patients. And both of these publications are already in the print.
Okay, fantastic.
Thank you for appreciation.
Fantastic. I think we must move on. Thank you for the great presentation. Our second presenter of the evening is Dr. Yeo Tun Kwan from Tan Tock Seng Hospital in Singapore, and he's going to give us some light on total keratometry in IOL power calculations. Tun Kwan.
Hi, I'd like to thank the Bangladesh Society of Cataract and Refractive Surgeons and BSCRS for this invitation. And I'm going to talk about total keratometry in IOL power calculation. So we know standard keratometry only measures the anterior corneal radius, and then this radius is then converted to corneal power using the keratometric index. So depending on where you are, this can be 1.3375 or 1.3315. So there is a presumed anterior to posterior corneal relationship. So what this does is actually it's estimating the posterior corneal power to give an overall corneal power. However, recently the APACRS 700 introduced a new parameter called total keratometry, or TK. What it does is it measures the anterior corneal radius, and then using the swept source OCT, it then measures the posterior corneal radius and central corneal thickness, and in combination, it gives you total corneal power. So instead of estimating the posterior corneal power, now we are measuring it. So the main question here is, of course, whether total keratometry leads to more accurate outcomes. So there are a few papers. Here is a paper by Dr. Sabong, which looked at 60 normal eyes, and they showed that the Barrett Universal 2 with TK had the lowest mean absolute error, and there was a trend towards lower mean absolute error and median absolute errors when used TK compared to K. Here's another paper by Dr. Fabian, which looked at 145 eyes, and they found that by using TK compared to standard K with the Barrett Universal 2 or the Barrett toric formula and the Haigis formula, they could achieve a lower mean absolute error for both spherical equivalent and cylinder prediction. However, apart from these two papers, there really isn't any more publications on TK in normal eyes or toric IOL. So this may be because that the posterior cornea variation is not that high in the normal eyes. So the benefit of total keratometry may be more apparent in the eyes with abnormal corneas, such as patients with previous LASIK, previous RK, or keratoconus. Here is a paper by Dr. Lee Wang and Professor Doug Cook, which looked at 129 eyes with previous myopic LASIK, hyperopic LASIK, and RK, and they compared the Barrett True K without TK, the Haigis L formula, and the standard Haigis formula using TK. And for the myopic LASIK eyes, they found there was no difference between the Barrett True K and Haigis TK. For the hyperopic LASIK eyes and the RK eyes, there was no difference between all three formulas. So what this really shows is by applying TK to the standard Haigis formula, it could achieve results equivalent to the Barrett True K no history formula. Here's another paper by Dr. Michael Lawless and Professor Graham Barrett, which looked at 72 eyes, 40 with myopic LASIK and 32 with hyperopic LASIK, and they compared even more formulas, which include the BSCRS average, the Barrett True K formula, and the Barrett True K with TK formula for the first time, and the Haigis L formula, the Haigis TK formula, and the Sharma's PR formula, as well as the Holiday 1 formula with TK using a double K method. And what they found was there was an improvement in the Barrett True K with TK, and for the myopic LASIK eyes, this was statistically better than the BSCRS average, Haigis L, and Sharma's PR. And for the hyperopic LASIK eyes, it was better than the BSCRS average. The charts showing the percentages for the myopic LASIK eyes, you can see that the Barrett True K with TK performed the best, and you can see that the Haigis TK also performs pretty well, which is in concordance with what with what Professor Doug Cook showed in his previous paper. For the hyperopic LASIK eyes, you can see that the Barrett True-K is doing better than Barrett True-K without history. First, we also did a paper and a study on total keratometry in previous myopic LASIK refractive surgery patients. This was 64 eyes with previous PRK or LASIK. We wanted to compare the accuracy of formulas with and without TK, and we included the Barrett True-K, Haigis L, Sharma's PL, Barrett True-K with TK, and most importantly, we wanted to find out whether non-LASIK standard formulas, when you use TK directly or with a reverse double K method, could these non-LASIK formulas predict for post-LASIK cases? And these included the EVO, the Haigis, Q, Hole A1, and SRKT formulas. Results. You can see that the Barrett True-K is doing better than Haigis L and Sharma's PL, but then if you add TK to Barrett True-K, it's performing even better. Here are the standard non-LASIK formulas, and you can see that they don't do very well because they are not meant to predict for post-LASIK eyes. But then what happens if you add TK to them? And you can see there is a significant improvement in these formulas. And here is the EVO with TK. Here is the Haigis with TK. And even the traditional Q, Hole A1, and SRKT formulas were doing better with TK. Here's the table showing the results. The Haigis L and Sharma's PL formulas are popular formulas for post-LASIK eyes, but here you can see they have a myopic tendency, and they had the highest mean absolute errors and the median absolute errors, whereas the TK formulas, which included the Barrett True-K, EVO, TK, and Haigis TK, all performed very well with the lowest mean absolute error and median absolute errors, and 3 of these formulas were all statistically better than the Haigis L and Sharma's PL formulas. So our findings was that without TK, the Barrett True-K performed better than Haigis L and Sharma's PL. But then when you add TK to the Barrett True-K, it improved even further. What was most interesting was that the standard non-LASIK formulas were able to predict for these type of cases with a reverse double K method. And these 3 formulas, the Barrett True-K with TK, EVO, TK, and Haigis with TK, all perform the best when you use total keratometry. So in conclusion, I think there is good evidence that total keratometry is beneficial in the myopic refractive surgery eyes, especially with these 3 formulas. And then there's also evidence for its use in the hyperopic refractive surgery eyes. And this may suggest that when you have the TK parameter, actual clinical history may not be required. So instead of using actual clinical history, or when it's not available, the total keratometry parameter may actually replace that. However, for the normal eyes and eyes with astigmatism or for toric IOLs, we really probably need more evidence because, as I mentioned, the variation in the posterior cornea is not so big in the normal eye. And so we really need a larger number of patients and a larger studies to elicit any benefits for TK in these kind of patients. Thank you for your time.
Thank you very much, Tun Kwan. That was a very comprehensive overview of the True-K and the TK. Can I just check, has Graham logged in? Because otherwise I would ask Graham to help me with this discussion. Anyone? Wing Kwong, Kathy, is Graham there? If not, let me just ask Tun Kwan one question. Tun Kwan, your first slide, I think you had one slide showing keratometric index of 1.3375 and 3315. Now that's something that's always on the Barrett calculator, and we never get a very clear explanation. Can you just tell us what it is? Do we need to pay any attention to it, or can we just ignore it?
Well, basically the keratometric index is just an estimation of the cornea power. So the 1.3315 is probably closer to real cornea power, and the 1.3375 is an overestimation actually. So basically, it's just for convenience, so that when you get a K of 44, you get about 7 point something millimeter in radius. So it was just for convenience. It's not a real cornea power. So, but the 1.3315 is probably the more accurate one. But you don't really have to worry about the K index. You just need to label it, choose the correct one when you're using the Barrett-Toric formula online or any formula online, because all formulas convert the K into radius. So, and the radius is the ultimate value that we're looking at, and not the K index in any formula.
So we should be using 1.3315 is what you're saying?
No, it's just a location area. So in Europe, people use 1.3315, and in the US and locally we use 1.3375. But you don't really have to worry about it, because all formulas convert the K into radius. So depending on what K index you have preset or chosen, you convert accordingly. So we
can ignore it.
Yeah. Yeah.
So we can ignore it. That's really what we need to know. Okay, Abe, do you have some comments on his presentation and the use of TK or total K?
I think must thank and recognize Graham Barrett and Doug Koch and all the stalwarts. And we are realizing now that if you really want to do a very precise, and we need that in toric IOLs and multifocal toric IOLs, and including monofocal, we need to go for total K now, whenever it's possible. The Zeiss machine, the newer one, gives TK values automatically, but we need to measure and put it that. And Graham has made it very simple for all of us. So I think we need to understand the importance of measuring total K.
I think what we should do is perhaps we should move on, and at the end, when we have time, I think hopefully Graham will have logged in by then. We can ask his comments on this. Let's move on to our next speaker, and that's Dr. Lee Man Wai from Ipoh in Malaysia, and he's going to talk to us on a new hydrophobic injector system. Man Wai.
Good evening, everyone. My sincere thanks goes to the Asia Pacific Association of Cataract Refractive Surgeons, as well as the Bangladesh Society of Cataract Refractive Surgeons, for this privilege to present at this webinar today. So my topic is to talk about some initial experience of myself with the new hydrophobic acrylic intraocular lens with a novel delivery system. My financial disclosures are as such, and relevant to this talk will be for Alcon. And this video shows the first ever PMMA implant being implanted by Harold Ridley in 1949. I think we're coming towards the 71st anniversary. It was done sometime in November, I believe. As you can see, implant surgery has come a long way since then, and incisions are smaller, and the journey has been quite an exciting one, or at least for me. So as mentioned, 1949 was the first implantation of PMMA IOL. And of course, 1967 was a landmark when Charles Kelman invented phaco, and subsequently all our cataract incisions became much smaller. But it took till the 1980s before there was uptake of foldable silicone IOLs. 1990s, where the acrylic foldable lenses came into play, and subsequently the rest is history. As from the 2000s onwards, I think the predominant lens that we use nowadays are acrylic, be it hydrophobic or hydrophilic. So all these different materials have been mentioned, and they have different properties. So the PMMA can be rigid, but we needed foldable lenses when the incision became smaller. Silicone IOLs serve that purpose, but there were reports about inflammation and perhaps increased risk of endophthalmitis. But the later generation silicone IOLs are quite good and are quite good now. Posterior capsular opacification was also an issue, and calcification specifically in the hydrophilic IOLs was an issue, but the newer generations one, again, very rare to see those. Glistenings were something associated with hydrophobic acrylics, and these are some of the photos of some of my own patients with such problems. Now, what's the ideal IOL material? It has to be biocompatible, obviously. It has to stay in the eye for many years. It has to be flexible to fit through smaller and smaller incisions. High refractive index so that you don't have thick lenses, but very nice thin lenses with the appropriate power. And the ocular environment is such, the IOL material has to be very similar to ocular environment, or at least very inert, because it's going to be in there for a long time. And the optic edge is very important, as we actually place a lot of emphasis on the reduction of posterior capsular opacification. So the lens I'm referring to is actually from Alcon. It's called the Clarion lens. And one look at it actually looks very similar to its very well-established APACRS lens. And in fact, if you do compare them side by side, the design is almost identical. So you have the 6mm optic, the haptic, stable force haptics, and the anterior is spherical surface. Now, what is different is really the water content. So the water content for the Clarion is 1.5 plus minus 0.1%. It's still hydrophobic, and the refractive index is the same, and it's also still a blue light filtering lens. What is also unique about the Clarion is that it comes preloaded in a novel delivery system, and they call it the autonomy. The autonomy itself is a fully disposable and automated system whereby it uses the principle of a canister of carbon dioxide gas, which is punctured when you depress this lever here. So a jet of carbon dioxide comes out, pushes a piston, which folds the lens and delivers it into the eye. And I'll have some videos to illustrate this. So what I'm talking about today is really a clinical evaluation of this lens. It was an investigator-initiated trial in Malaysia and a multi-center review of cases that were done. I'm just presenting my own personal data for the purpose of this webinar. So the study design is relatively straightforward. Inclusion criteria: patients who are undergoing phaco with a monofocal Clarion IOL, less than 1 diopter of astigmatism, excluding patients with significant ocular pathology, previous refractive surgery, and of course, intraoperative complications. Study endpoints, again, very straightforward. Primarily, we wanted to look at the best corrected and uncorrected distance acuity at 1 month. We wanted to look at the refractive predictability and outcomes of the lens at 1 month as well, looking at contrast sensitivity. And for those who had bilateral implants, we wanted to do a VF14 quality of life questionnaire. And because of this novel delivery system, we also wanted to look at whether the wound would get extensively stretched and whether there was any induced astigmatism from this. So this table just highlights the schedule of visits, which is obviously in the pre-op setting. The usual examinations were done. Day 0 will be surgery, and subsequently first day, first week, and first month post-op. If you look at the pre-op parameters, this is a typical cataract age group, a mean age of 65. 47 eyes were done. 11 of them patients had bilateral surgery. Axial length, very common axial length, no extreme axial length here. And correct acuities are as shown here. Not too bad, 0.5 and 0.7 logMAR. If you look at the visual outcomes, what's reassuring to see that all the post-op patients had good visual outcomes, in the sense that the post-op best corrected was close to 0, which is 6.6 or 20/20. In this case, 0.08, it's around about 6.7.5. And the uncorrected vision was about 6.9 in the majority of cases. So if you look at a percentage of cases with best corrected better than 6.9, it was over 90%, and all eyes best corrected better than 6.12. Uncorrected, more than 75% better than 6.9, and 96% better than 6.12. When you look at refractive outcomes over here, we're looking at mean arithmetic error and mean absolute error. And what this basically looks at is the spherical equivalent at 1 month, minus out the target refractions. And we look at the mean error here. And the arithmetic error is looking at how close to ametropia, which is the target in all the eyes. So we're very close there, close to 0. Now, the absolute error is essentially looking at how far off we are from the target. So we discount the minus or plus signs in the sense where it's hyperopia, myopia. And we see that within a quarter of a diopter is our mean absolute error, which is very good. Stability looks at the change from the first week of the refractive outcome with the 1 month, and we find that there's very little change, which indicates that the lens sits well after a week, and it doesn't change very much coming up to the month's follow-up. Refractive predictability, looking at the number of eyes that fell within 0.25 diopters of our target, and these are all using the Barrett formula 60% of the time, and 87.2% within 0.5 diopters, and all eyes were within 3/4 of a diopter. So these are very good results. Contrast sensitivity, we also did at 1 month, and this is looking at the CSV 1000 contrast chart, typical contrast sensitivity testing. This is what a chart recording would look like, and the grayed out zone would be where the normal contrast sensitivity would fall into. So if you look at the mean and the median contrast sensitivities in the relative cycle per degrees, you can see that the average is around about 5. And you look back at the chart, 5 is towards the normal or within the normal gray zone here. So all eyes did achieve normal contrast sensitivity with this lens. We look at a VF14 questionnaire. There were 11 patients. So this questionnaire essentially just looks at the different tasks or visual tasks that are required and how they did with this lens in place for bilateral patients, even with glasses. So if you see very good scores here, majority of the eyes were above 90%, and patients were quite happy and satisfied in this group of 11 anyway. When we look at wound stretch, so I'm a 2.2 millimeter temporal incision surgeon, and I do a wound-assisted IOL delivery. So we use the incision gauge to measure the wound size just after phaco and before IOL implantation, and just after IOL implantation to see whether there's any stretch. And then we calculate the SIA by looking at the post-op case and the pre-op case using the calculator by Warren Hill on that website. So the study here the chart here just shows that pre-op, is very close to 2.2, and the post-op 2.27. So there is some stretch there, and the mean amount of wound stretch is actually less than 0.1 millimeter, 0.06 millimeters. And surgically induced astigmatism is also minimal, about less than half a diopter, which is quite good. So this is just a video to illustrate the injection and the preparation process. On the left side here, you have the microscope view, and on the right will be the external view. So you start off by injecting viscoelastic into this little port, and you fill up the whole cartridge up to the tip, and you pull out this safety lock, which actually comes because it's preloaded. So when it's packed in, so that prevents it from accidentally depressing the lever. So as you see, when I click the lever down, and you see the lens being folded nicely under the microscope. So when you take your finger off, it will stop where you want it to. So if you keep pressing, the whole IOL will get delivered. So I use a wound-assisted technique. As you see here, the tip does not go fully into the AC, and very smooth delivery of the lens, and a lot of control afforded to the surgeon, as when you lift your finger off the lever, you would then stop the progression of the lens, and it depends how much you press down, and it controls the speed of delivery as well. So my initial experience with Clarion has been a good one, in the sense that the visual outcomes from that small study that we've done, at least my own personal data, you get good visual outcomes, predictable refractive and stability, and good contrast sensitivity with good visual field, VF14 quality of life scores, minimum wound stretch and SI, and surgically induced astigmatism. The autonomy is a nice novel delivery system. In fact, it's very intuitive to use, not difficult at all, easy to prepare, preparation, and minimal learning curve. And really, I find that the delivery is very smooth and much smoother compared to the usual twist type or the plunger mechanisms. So I thank you for your time, and I hope all of you would have the opportunity to try this lens in the future. Thank you very much.
Thank you very much, Manwai, for that presentation. Quick question, any complications with the automated system?
I've not had any complications so far. Basically, there are certain things that you have to do. You have to use the correct viscoelastic. If you don't have one that's correct viscosity, sometimes it doesn't fold the leading haptic properly. And there's couple of occasions where the back haptic as well does not get tucked onto the lens, so it can come out a bit straddling and a bit loose. So I've not had any where they actually got
nothing serious. Okay, that's good. One more question for you. Does a different water content between the Clarion and a standard APACRS make any difference in the performance of the IOL, optically speaking?
I think when you talk about performance optically, in fact, I don't think so. In fact, I think if you look at the lens clinically on the slit lamp, it actually looks very clear. The yellow tinge is a little bit less than your APACRS, but I think essentially what could be addressed is the long-term issues that we know about the subsurface nanoglistenings with the previous material. And so far, I think this study is not powered follow-up long enough to look for that. But I think with the water content being actually higher than the APACRS, then that should address that, hopefully. Yeah.
Okay, could I just ask Dr. Chowdhury, or do you have a comment to make, Dr. Chowdhury?
The initial experience by Dr. Moon looks wonderful, and the Clarion, but we didn't have an opportunity to use this. But the result that Dr. Moon shown, maybe we are definitely interested to see how it works in our hands. Thank you.
Thank you. Abe, you have a question.
I think I wish that the surgeons have an option of using this lens with a conventional packaging. At the moment, there is only injectable form, preloaded. So I think we should have an option. And we need to really look into, as Munwai said, the long-term effects of the, particularly PCO, because there is an hydrophilicity difference in these two lenses. And a similar thing was in good old days when we did a PCO study for Alcon and Acrisoft versus Sensar, that there was a subtle difference. So we need to look for and have some studies which look into this.
Actually, I
don't have enough experience of this lens, to be honest.
I wanted to ask Munwai, so is it the preloaded thing that you value more, or the automated injector that you value more in this new product?
Well, honestly, the actual injector system is very nice, but I think it's just an extra. I think what's more important to me is the optical performance of this lens and the clarity. And PCO, I think you need longer term follow-up. I think I have some patients that are coming to a year plus now and really no PCO so far, but small numbers. So,
we must move on. Thank you very much. Our next speaker is Dr. Cho Yong Choi from Seoul in South Korea. And he's going to talk to us about really comparing the different options for trifocal or multifocal IOLs. The next 3 talks about multifocals. Please go ahead, Dr. Choi.
I'm Dr. Choi from Seoul, Korea. I will cover a new different options for presbyopia correction. And recently, we have been publishing the comparison of a mix and match and bilateral trifocal IOLs. And briefly, in this slide, I will show a little bit more about the comparison of a new trial of EDOF and trifocal IOL. We have been working on a variety of laboratory works regarding optical and physical analysis of multifocal IOLs. And also we published different EDOF IOLs showed different optical characteristics in the bench test, depending on the pupil size and spherical aberrations. We have been conducting a couple of studies with the same platforms using a variety of options for multifocal IOL. And first one, we published about a comparison of a monofocal IOL and EDOF IOLs in prospective study design. And we could see the uncorrected focus levels. EDOF shows a better superiority when you compare the monofocal IOLs in the focus curve. And EDOF IOLs show the better tolerance to residual post-op refractive error than monofocal IOL with the same platforms. From this slide, I would like to share my recent work comparison of the mix and match and bilateral trifocal IOL, and also I would like to share a little bit more about the mix and match using different platform of EDOF IOL and different platform of trifocal IOL. All of these studies were prospective one bilateral implantation of a multifocal IOL in 25 patients in each groups, and mix and match groups. We implanted an EDOF IOL for non-dominant eye and bifocal IOL for non-dominant eye. These are the pre-op and post-op examinations, and visual acuity and uncorrected defocus curve, and contrast sensitivity, and the reading speed, and all kinds of questionnaires were done. This is a slide of a pre-op demographics, and both groups did not show any statistical difference. And this slide showed the post-op 6 months of clinical outcomes of visual acuity. And if you look at the monocular outcomes here, and the EDOF and bifocal and trifocal groups showed a different result. And best one was EDOF groups. And the best one for the near visual acuity is quite a similar outcomes with the bifocal and trifocal. And we can see binocular implantation result of a mix and match and trifocal group here, and quite a better outcomes in the mix and match groups. Is a better outcome with the near visual acuity in trifocal group, but did not show any statistical difference. This is a slide showing the uncorrected defocus curve. Here, blue one is EDOF IOL and the green one is bifocal IOL. When you put the bilateral implantation of both IOLs, as we can see red graph of the uncorrected defocus curve here. This is a slide of defocus curve unilateral implantation of a trifocal IOL panoptics here. And if you put the bilateral implantations, and we can see much better outcomes compared to the unilateral one, and much broad and smooth curve in all ranges. When you compare the two groups, mix and match and bilateral trifocal panoptics IOL here, we can see 3 different points of statistical difference here, and the far and close to the far point. In that point, and mix and match shows better outcome in the focus curve, and extremely small area similar to J1, we can see better outcomes statistically different in trifocal IOL in the focus curve that we published in the same graphs and recently. Going back to the clinical outcomes, if you only see the far and intermediate and near visual acuity comparisons, it is hard to understand the complete characteristic of each options. If we understand the uncorrected defocus curve outcomes here, and it is easy to explain to the patient, and also patient can understand easily with which one is much suitable for their eyes. This is a slide showing our ongoing another studies using a different platform of EDOF and the trifocal IOL for mix and match, and blue one as we expected, quite nice graphs compared to both groups. And also we are conducting a prospective bilateral implantation of eye hands and premium monofocal IOL here, and you compare 3 options for mix and match and eye hands bilateral implantation with trifocal panoptics. It is quite easy to show the clinical outcomes for the patient, and the patient can understand much quite easily with these graphs which options they should choose. This is a slide showing the spectacle independence rate, and mix and match groups far and intermediate independence is quite higher than trifocal groups, and near foci is quite a similar pattern was observed. And regarding the photic phenomena and satisfaction questionnaires, and we could see and quite a similar pattern of photic phenomenon, especially about the starburst was observed in both groups, and glare was a little bit higher in the mix and match groups, but overall satisfaction was a little bit higher in the near foci with the mix and match groups. It's quite interesting research we could observe here. This is a slide showing the reading speed test using a Korean letter Hangul. It's quite a complicated design similar to the Chinese or Japanese letters. When you look at the graphs here and the mix and match, the red ones show the better outcomes and statistically different in 2 points, and then bilateral trifocal implantation and the large to medium size of letters. But when you look at very smallest letters, J1 to J2, it's quite a similar result was observed, interestingly. This is quite a similar outcomes with the defocus curve and contrast sensitivity. This is a slide showing the contrast sensitivity test, photic, mesopic, and mesopic with the glare test with the CSV 1000. The best outcome was observed in the bilateral EDOF IOL groups. And when you compare the mix and match and the bilateral trifocal group here, and a little bit better outcomes with the mix and match in some foci, but there was no statistical difference in overall the research here. In summary, mix and match strategy using EDOF and bifocal or trifocal IOLs could be an effective option for improving near visual outcomes with excellent far and intermediate visions. Also showed a similar pattern and a tolerable range of photic phenomena and higher rate of overall satisfaction in all foci compared to bilateral EDOF IOLs. And mix and match strategy also provided overall improvement in visual functions and the reading speed. Thank you for your attention.
Thank you very much, Dr. Choi. Graham, I just see you appearing on screen. Do you have a comment to make on this particular presentation or the previous one? Sorry, I didn't see you raising your hand.
Ron, more for the previous is I've had the opportunity to use the Clarion for more than 2 years and including toric Clarion for over 12 months. And I don't see a difference in PCO. And just echo all what Manwai has said. It really is an excellent lens. And I'm not sure, Abe, why you would like to have the conventional injector, because I think one of the attractions is the preloaded. The automated is not quite as clean an insertion, but the fact you don't touch the lens, I think is a really nice advantage. I really like this lens.
Well, no, I'm not against the lens or for the lens, but I'm not really convinced about the injector versus what we are using. All these benefits we know, and it's common sense, may be there, but I don't see a big deal about it. So there should be an option to that, and I'm really hoping that we will have that one day.
You prefer a conventional injector?
At the moment, I do not use injectors. I did some studies on a wound, and I think, I don't want to comment, but we really, if you want to understand the injector distortion, we need to have a high resolution OCT stuff and things. And studies have shown that there is a uncertain distortion collagen stress to the incision with injectable.
Okay, I think we need to move on a little bit. I want to do the next 2 talks and then have a chat about multifocal IOLs in general. So my pleasure to invite Dr. Muhammad Rosman from the Singapore National Eye Centre, who's going to tell us his experience with the new EDOF trifocal IOL. Rosman.
Good evening, friends and colleagues. Before I start, I'd like to thank the organizing committee of the Bangladesh Society of Cataract and Refractive Surgeons for inviting me to give this talk. I also like to thank the APACRS committee for giving me this opportunity to present my talk today. I'll be talking about combining the best of both worlds, my initial experience with an EDOF trifocal intraocular lens. So as you know, the intraocular lens has evolved over the years since cataract surgery started. From monofocal, which gives good distance vision, to bifocal lenses with high ad, which gives you good distance, good near, but poor intermediate. Further evolution of this lens with bifocal medium ad gives good in distance, good intermediate, but poor near. And nowadays we have trifocal lenses, which give both good distance, good near, medium intermediate, slightly poorer depth of focus. And there are certain lenses with extended depth of focus, which gives good distance, intermediate, and good depth of focus. However, what's next level of evolution? Is there an IOL that can provide good distance, intermediate, and near vision, while at the same time give some level of extended depth of focus? That's the aim of the fine vision Trim lens. How does this lens achieve this? The basic technology is still a trifocal technology. Okay, the fine vision utilizes the basic trifocal technology. However, with certain patented technology, it aims to provide some degree of extended depth of focus. The fine vision Trim utilizes the technology from the fine vision Port F, which is an apodized diffractive lens. However, for the Physio Trim, as you can see here, there is no apodization. The steps are the same throughout the size of the optics of the intraocular lens. And because of this, it results in more intermediate energy distribution and a more gradual energy distribution from distance to near. As you can see, for the Port F, the energy distribution is more for the distance and the near, while there is actually a dip in intermediate. Whereas in the new TRIME, there is a gradual reduction in energy distribution from distance to intermediate to near, and this provides a bit of a elongated depth of focus. So it's slightly different technology compared to the Symphony. So as I mentioned, the energy distribution, the monotonic energy distribution, due to the similar steps of the in the lens optics, allows a monotonic decrease in energy allocated for far, intermediate, and far near without any gap for the intermediate vision. So again, when we compare versus the Symphony, where you can see there's the good high energy distribution for distance and intermediate, but for near is markedly reduced. In the fine vision TRIME, it aims to provide good distance, intermediate, followed by near vision. So if you look at the light distribution in terms of pupil aperture size, because it's not apodized compared to the fine vision port F, where in the fine vision port F, in dim light, there is more energy distributed towards the distance, but for near and intermediate, the energy levels reduced to 24% and 9%. Whereas in the Physio TRIME, the energy distribution is roughly uniform, regardless of the pupil aperture size. Even in dim light, there is sufficient distance vision, intermediate, and near vision. So basically, as I mentioned, based on the difference in diffractive profile of the two lenses, the TRIME is able to provide good distance, intermediate, and near throughout all pupil size. The light transmission is also superior in the TRIME, 91% light transmission at 2.5 millimeters of pupil aperture. The other technology that is used in this lens to improve the quality of vision is the reduction in longitudinal chromatic aberration. So as we know, whenever white light passes through a refractive surface, the difference in refractive index of the different colors results in chromatic aberration. And we know that studies have shown that this longitudinal chromatic aberration may degrade the quality of retinal image. It results in some degree of waxy kind of vision. So this is particular so it be index lower compared to the hydrophilic lenses. So as we can see here, whenever there's a refractive surface, there is a positive longitudinal chromatic aberration, whereby the blue light is refracted more compared to the red light. And this results in the chromatic aberration. So how does this lens attempt to correct this LCA? So again, just to recap, as light passes through the refractive surface, there is a positive LCA due to refraction. Okay. But when there is a diffractive surface, it does the opposite. It results in a negative LCA, whereby red is refracted more compared to green, followed by blue. So this is the opposite to the positive LCA due to a refractive surface. So in the Physio TRIME, the design of the lens aims to compensate both positive and negative LCA. The refractive surface together with the diffractive surface compensate each other and results in reduction in the reduction longitudinal chromatic aberration. So using the positive chromatic aberration from the refractive surface and the negative diffractive chromatic aberration, they aim to compensate this process and results in a reduction in chromatic aberration. So this results in, as you can see here, color alignment in both the intermediate and the distance vision. Okay, therefore, it helps to compensate for LCA in this in the distant vision and the intermediate vision, resulting in clearer and sharper vision at these distances. So this can be seen in the USAF target. You can see that for the trifocal, there's good far and near, but the intermediate is not so clear. And in Symphony, there is good distance and intermediate, but not so clear near. Whereas in the Port F, you can see that while far vision is good, there's reasonable intermediate and near. And there's a gradual reduction in, reduction in the depth of focus. So in summary, the fine vision triumph provides trifocal vision, which is pupil independent. It has a monotonic energy distribution, which results in the elongated depth of focus, and also reduction in longitudinal chromatic aberration with improved in quality of vision. Okay, just a video of how this lens is inserted. So this is the injector. You have to fill up the injector with viscoelastic and also the grooves. Okay. So this is how the lens comes. Okay, this is how it looks like. We will lift it up. Okay, placed it in the cartridge and close the cartridge. Okay. Okay, next we will engage the plunger. And inject the lens into the eye. So it's quite a straightforward loading and injecting process for this lens. Okay. The most important to make sure that the two leading haptics are under the anterior capsule, right? And then you just tuck the posterior the trailing haptic into the back. Okay. All right. And remove the viscoelastic. I usually remove the viscoelastic from the posterior to the lens first before removing from the front. Okay, and that's it. Okay, so how does it compare with the existing Physiotrime? How does the Physiotrime compare the existing Port F, which is a trifocal lens which also produced by Fine Vision? So you can see for distant vision, at 1 month, both gives good distant vision, high percentage of at least 6.5 vision, right? So in fact, it looks from this two comparison, the Trime, or the Port LGF, gives a superior distance vision for both at 1 month and at 6 months. If you compare the near, so as mentioned, there is some reduction in near vision for the Trime. However, it still gives sufficient near vision, at least N8, N6 for most patients. Of course, the Physio Port F gives better near vision, a high proportion achieving N5, N6, and N8. But if you compare the intermediate, the Triumph is better. Okay, it's superior, higher percentage achieve at least N6 vision compared to the Port F. And both lenses give very good refractive predictability, very close to the intended target. In terms of glare and halos, less patients with the Triumph. There's less glare and halo size in terms of in size and intensity in patients with Triumph compared to the Physio Port F. And if you look at defocus curve again, you can see that for the Port F, there is a twin peak at the distance and near. However, for the Triumph, there is a peak at the distance and a gradual decrease intermediate to the near. So in conclusion, the Fine Vision Triumph intraocular lens is a promising IOL which provides good distance, intermediate, and near vision. And the ability to provide better quality vision with elongated depth of field will generate greater satisfaction among patients. However, a larger and longer term studies will be needed. And also a toric version is needed. Currently, the current version is non-toric. Thank you very much.
Thank you very much, Rosman. Quick question. I mean, Do you think this is superior to a standard trifocal in your experience? But you've used quite a lot of trifocals and this combined trifocal EDOF in your limited experience, but do you think it's superior?
I think it really depends on the patient, because if the patient really wants to do a lot of reading, a lot of fine near work, I think the trifocal is still superior to this. But for this lens, I think for patients who are generally younger, who are more computer savvy, who use a lot of digital devices, and they want to be able to do this in slightly dimmer lighting condition, I think this lens is probably superior.
Anyone else on the panel tried this lens before?
No.
No. Okay, I think let's move on to the last presentation on the trifocal discussions. Our next speaker is Dr. Tanapong from Bangkok. He's talking to us about how to hit the right target with multifocal IOLs. Tanapong.
Good evening, everyone. I'm Dr. Thanapong from Chulalongkorn University, Bangkok, Thailand. First, I would like to thank the APACRS committee for the invitation for this webinar. My talk today going to be about the digital reading performance with multifocal IOL. And this is my financial disclosure. In this COVID-19 pandemic year, we're familiar with the word new normal, or some people say it's new abnormal. For myself, I'm gonna say it's now normal because the world is already changed. And actually, someone say it's no normal because it's just the way of life that keeps changing all the time. My talk today, of course, gonna cover about the digital disruption and the generation. We go through the digital reading and the multifocal IOL to read with the digital devices. We touch a little bit on the precision cataract surgery and summary of the talk. Among the generation, our cataract surgery mostly being the baby boomer generation and some of generation X. This generation, for the presbyopic correction after the cataract surgery, can be glasses. It can be reading glasses, bifocal or progressive glasses. Mono vision still play a role, but you're gonna lose some benefit of the visual field. Multifocal IOL is another option which provide all range of vision and including the reading performance. This is the patient today. They are very active lifestyle, and you see how she performed well with the digital reading on her mobile phone after bilateral cataract surgery with multifocal IOL. And this is the picture show the text size of patient use. This is similar to what I use now with the distance about 33 centimeter. This is my table in my room. Actually, in this era, you cannot go just for paper or just for the digital device, but actually, we use both of them. In conventional paper and the digital reading, it shares some characteristics when you read. The text size, payroll, text design, contrast, color, and ambient illumination also play a role. And we all know the multifocal IOL implantation normally need the high illuminated ambient to read well. But they have some factor that's specific for only digital devices: skin illumination, digital display format, digital polarity, which can have positive polarity, is mean back on white color, and also negative polarity, which is white on back. Get light reading, which is when you have the mobile phone and you have notification, you need to move your eye toward the notification. That is get light reading, that's specific for the digital device only. And another term of the DES or digital eye strain can happen when you read long enough in the digital devices. Reading performance outcome measurement We performed the study and we used this uncollected binocular intermediate visual acuity and uncollected binocular near visual acuity in bilateral implanted multifocal IOL. And we measure at 60 centimeter for intermediate vision and 42 and 33 centimeter for the near vision, because we use it in different way. Intermediate vision for the PC or tablet use, 42 centimeter usually for the tablet use, and for the Asian people, our arm length is a little bit shorter, so mobile use may be better with 33 centimeter, not 40 centimeter. Leading speed was evaluated and digital eye stain also. And we also changed some setting on the devices such as skin illumination, display format, and polarity. Of course, what we found that leading pupil size is very important to for the leading performance in digital devices. Leading with multifocal IOL. We have so many design of multifocal IOL in the market now. Pupil size, of course, as I said before, is important for the performance, but also the design of the IOL. The central area can be distant, can be intermediate, that affect the performance. The apodite or non-apodite also affect too. And the study that we did, we test the paper reading compared with the tablet reading. We use different lume light, like the dim light illumination, and we use both black and white on back tech on the digital devices. This is our setting. We're setting black on white and white on back on the 100% illumination of the lume and 50% of the lume illumination. And we also change the blindness on the skin of the tablet. This is our outcome. Actually, in the patient that do bilateral multifocal IOL implant, the binocular uncollected defocus curve look good. They have like 20-25 vision in all range, and this should cover the leading on the digital devices like the PC, tablet, and mobile phone. We also do study on the back on white. If you see the graph on the left hand side, the y-axis is the visual acuity. In 30 centimeter, the visual acuity dropped down, but it's also within range of 20-25 vision. When we reduce lume and skin illumination, the vision dropped down more, but still within 20-25 vision in 40 centimeter and 60 centimeter. Same thing with white on back. They need the illumination to increase visual acuity for digital reading in all lenses. And if you compare the white on back and back on white, it seems to be white on back going to be a little bit better. Back on white going to be a little bit better compared to the white on back. This is to show you how back on white of 25 vision at 30 centimeters is very small. But you need to understand that to lead with comfortably, it not mean you need to lead the lowest text size, but you have to understand about the clinical print size that normally 2 times larger than equity letter. We may use this to setting up the text size on the digital devices for the patient with multifocal IOL, depend on visual acuity that they post-op visual acuity. In summary, reading with paper and reading with digital device, reading with digital devices tend to have better visual acuity compared to paper reading. And back on white tend to have better vision compared to white on back. Precision cataract surgery, we all know Our ophthalmologist team job is to deliver the best possible visual outcome to patients, and happy patients is a key. How to get happy patients? Patient expectation, pre-op counseling and patient selection is very important. Multifocal IOL design also play a role. Hit the target refraction is very, very important. Precise biometry, use of topography, IOL formula balance is a very good one. Low toric correction is very curious to get the target refraction. In summary, digital reading with electronic device seem to have additional visual benefit in multifocal implanted patients. Hit the light refractive target is the key. Positive polarity enhance digital performance compared to negative polarity. Leading diffuse size and multifocal IOL design possibly play a role in digital reading performance. Adjust text size in digital devices. 2 times of the acuity enhance reading comfort. A larger well-designed study to evaluate digital reading is needed. And this is our team at Chulalongkorn University, and we hope to publish our paper about digital reading soon, early next year. And hope you have happy patients with happy surgeons. Thank you.
Thank you very much, Tanapong, for the very nice presentation. So we just had 3 presentations, or really 3 very different approaches to really trifocal, or the correction of presbyopia. And here, let's have a little discussion. I think maybe we can spare about 5 minutes on this very important topic. Abe, I'd like to know what your preference is today, and if you just say a word or two about why. Multifocal or monofocal?
Having tried different multifocal, now my first preference would be a trifocal lens, because in majority of the patients, if we discuss with them, they have quite an acceptable intermediate and sort of reading vision as well. So if you select the patient, that's my first choice. Sometimes I use a 2.5 low ad multifocal, also in some patients who really demand distance, clarity, and intermediate, and not bothered about wearing reading glasses. But generally, if I have to say in one line, trifocal lenses, my patients are getting more and more now.
What percentage of all your, say, private cataract patients would you say you put a trifocal or you know?
Before the trifocal came, it was about 6 to 7% that I was using multifocal, and now it is more than 20% of my patients who receive trifocal lenses.
Okay, well, I would just say that 60% of all my private patients get a trifocal lens, and that, Graham, is because of you. It's because of your formula that's allowing us to hit refractive targets that my rate of trifocal implantation and trifocal toric implantations have gone up significantly. Because as I've said before, we sleep so much better knowing that I can kind of promise patients, look, you've got a 90% chance of spectacle freedom using the Barrett formula and a modern trifocal. But I know, Graham, that you probably still do not use any trifocals at all. So perhaps you could just share with us, what your thoughts are and your reluctance to embrace trifocal technology or EDOF technology.
Well, Ron, I mean, you have to offer patients a presbyopic solution. And I use modest monovision because it gives me the greatest patient satisfaction with the least number of unhappy patients. And I use it in 75% of my patients, not 60% and not 26%. I don't really have to sit there and try and determine whether they're suitable or not, the profession, the type of person they are. And yes, I don't have the same level of spectacle independence as you would have with a trifocal. But to me, I don't find that that is the most important criteria for patient satisfaction. I find you need some degree of spectral independence, but you really can't afford to have people having night vision issues and halos. You can't afford to them just noticing, as you've seen on some of the presentations, that their MTF and their optical performance is not as good as a monofocal.
But Graham, the trifocals of 2020 are not the same as the bifocals of 10 or 15 years ago when we had them with the glare, halos, waxy vision. And I have to say, you know, in the last 5 years or so, that the quality of vision is, I so rarely have any patient complaining of any of these as a significant impediment to their full range of vision that they're enjoying.
They're definitely better, Ron, and you can definitely expand their use. I still don't think they would match up to the quality of a monofocal or even extend the depth of focus, but everything is a compromise, and it depends what you're prepared to compromise on.
No, I take your point entirely. I mean, when I say I'm 60% multifocal, the other 40%, they are all monovision as well. And I do that, you know, for the patients who are uncertain, if there's some pathology, and it absolutely works. I agree with you entirely, but I think having the trifocal does complement monovision tremendously. I think while we've got some other young surgeons on the panel, let me just ask some of them. Nato, what is your level of multifocal implantation in your private patients?
Thank you, Ron. Thank you very much. A great discussion going on the presbyopia correction for the different kind of multifocal IOL. And I like to thank all the presenters for the different attitude and different knowledge, different experience. And I think the 4 presentation on the Triumph, Adopt, and mix and match, all these things. And still I find we are yet to get the ideal multifocal for our—
What's your level of implantation?
Yeah. But I can see my experience that some of the patient I have given Adopt, and the same other I put the Panoptics. They are doing very good. Some patient have been restored, and recently I've given the Panoptics. They're also doing good. So I don't know, the mix and match may be a good option for many.
It sounded impressive, didn't it?
Yes, I'm really impressed on that. The mix and match can be still a good option. And definitely, as Graham Barrett said, the monofocal, especially the eye-hands lens or like the Clarion lens, probably is a good way for some profession at least.
Sure. Okay, let me just ask the young doctors very quickly now.
As a whole, I think multifocal with mix and match is still the best answer.
Thank you. Nato, what's your level of usage?
I go more with trifocal, and for my level in my private practice is about 50 to 55%.
Great. Vaishali, what's your level of usage in your private practice?
Again, I would say 15 to 20% trifocals, and not because of it's more financial, I think, that we get it more in our part of the world, but trifocal is my preferred lens.
Okay. John, unmute yourself, and what's your level?
I have not been back long enough to put that many multifocals, so currently it's less than 10%. Yeah.
Okay. Tung Kwan.
I'm putting about probably 30% trifocals because they take less chair time. You can just put it in almost every patient once you've screened them properly.
Sure. Manwai?
I'm pretty much like Vishali. I think in my neck of the woods, finance is a big issue. So about 15%, 20%.
If finance wasn't an issue, would you be much higher, do you think?
Definitely, yeah. I like trifocals.
Yeah. Ishtiaq.
Yeah, finance is a big issue for us here.
Okay. Rosman.
Probably about 40% of my patients are trifocals.
Okay, thank you. So, I mean, we can see that the range of usage is from 0 to about 60% in my case. So I don't think there's a right or wrong. I think you've just got to really get the best of each technology and choose the best thing for your patient, okay? So let's move on to our next presentation. And that's Dr. John Wong from Tan Tock Seng Hospital in Singapore. And he's going to tell us about something he learned when he was doing his fellowship with Ehud Asia in Israel. John, where you go?
A very good evening to everyone. I would like to thank the APACRS for giving me this opportunity to share about this topic, 6O polypropylene flange fixation of intraocular lenses. Scleral fixation of intraocular lenses can be performed with various suture types. These include 10O or 9O proline, but they are known to undergo biodegradation with time and may not be suitable for younger patients. The use of Gore-Tex has been gaining popularity, but it remains an off-label use item for the eye, and it comes with a large needle that may not be optimal to pass within the eye of patients. There are also sutureless techniques for IOL fixation, and this includes the glued fixation technique and Yamane techniques. These techniques avoid suture-related complications. More recently, the 6O polypropylene flange fixation technique was pioneered by Canabrava and is in essence a modification and expansion of the Yamane technique, where instead of creating flanges on 3-piece ILL haptics, the flanges are created on 5O or 6O proline sutures, and this method can be used in a wide variety of situations. The advantages include the use of this thicker suture that is more resistant to degradation, conjunctival peritomy is not needed, and knots need not be tied because we are using the suture to create flanges. It allows for easy titration of centration of intraocular lenses by repeated shortening of the proline suture and flange creation. Lastly, the proline suture can be passed into the eye without the need for needles. I will now demonstrate the use of this technique in 3 situations, starting with fixation of a capsular stabilizing device with 6O proline. This patient has a cataract with superior zonulolysis and vitreous prolapse that was only noticed on table by the primary surgeon. The primary surgeon decided to close the incisions and refer the patient. The red area highlights the region of zonular weakness, while the green line represents the area of prolapsed vitreous. We started the surgery by first clearing the anterior chamber of vitreous with anterior retractor. This was followed by CCC creation with vision blue visualization, and thankfully we were able to complete the CCC despite the significant zonular weakness. With the aid of capsular hooks, we then proceeded with uneventful phaco and irrigation and aspiration of soft lens material. A CTR is then inserted for equatorial support, and in such cases, I tend to first insert the intraocular lens prior to fixation of capsular stabilizing devices, such as a CTS. So a 27 gauge needle here is inserted 2 mm from the limbus, and it is used to receive the 6O proline suture through the main incision. The suture is externalized above the conjunctiva and a flange created. A CTS is then inserted, threaded through the 6O proline with a second flange created to prevent the CTS from slipping out of the suture. The CTS then is maneuvered into the eye and placed into the capsular bag fornix in the area of maximum zonular weakness. We then titrate the centration of the capsular bag and the intraocular lens by pulling on the 6O proline, and once we are satisfied with the centration, we can shorten the suture and create the flange again. Once we are satisfied with the final centration, the final flange is created, and we can tuck this flange under the Tenon's capsule and the conjunctiva. And we now have a stable capsular bag and intraocular lens. These are post-op pictures showing the flange flushed against the sclera, and patients generally recover faster and are more comfortable after surgery. The next case is for demonstration of intraocular lens repositioning and fixation with 6O proline. This is a 60-year-old male with poor vision in this eye of counting fingers closely. His previous best corrected visual acuity was 645. His retroviral positive, and this eye has prior CMV retinitis that has been treated and is inactive. However, he has chronic anterior uveitis that is currently quiescent. It is a guarded prognosis eye because of band keratopathy and fibrotic epiretinal membrane. And one can see the inferior subluxation of the IOL capsular bag complex, where the Sommering ring is visualized at the visual axis of the pupil. His pupils are also very poorly dilating. As you can see here, this is maximum dilation. And due to this history, I really wanted to do minimum for this patient, and I opted to reposition the IOL rather than to explant and fixate a new intraocular lens. I had to first stretch the pupil with iris hooks to obtain sufficient surgical view for surgery. Markings were then made 180 degrees apart, 2 mm from the limbus, at 4 and 10 o'clock in this view, and this was the position of the sclerostomies. A 27 gauge needle was inserted into the eye, passed under the first haptic, and received the 6-0 proline suture from the space in between the optic and the haptic. The same needle then enters the eye 1.5 millimeters from the limbus at the same clock hour, and it receives the other free end of the 6-0 proline suture, this time above the haptic. We now have a loop of suture around the first haptic, and movement of the IOL when traction is applied on this loop of proline indicates that the proline is correctly looped around the haptic. The same steps are repeated for the other haptic. And now we have both haptics being looped by 6-0 proline suture, and all that remains is to titrate the centration of the intraocular lens, followed by shortening of the 6-0 proline sutures, flange creation, and once again the flanges have to be tucked under the conjunctiva. And this is the end of the case, where we have a relatively well-centered capsular bag and intraocular lens. For the final case, I'll be showing the use of this technique for IOL fixation in aphakia. This is an eye with a severely phacodonatic white cataract for which we performed ICCE for. ICCE was performed through a scleral tunnel, and after expression of the cataract, we performed anterior vitrectomy in preparation of intraocular lens fixation. We use 6-0 proline with a round-bodied needle, and we pass the suture through both optic-haptic junction of this one-piece hydrophobic intraocular lens. Flanges were created to prevent the suture from slipping off the intraocular lens. As with earlier cases, we mark the eye 2 mm from the limbus 180 degrees apart. The 27 gauge docking needle enters the eye. We dock the 6-0 proline and externalize it on both ends. This gives us 2-point fixation. And once we've externalized the sutures, we can then insert the intraocular lens, titrate the centration of the lens. What's left of the surgery would be to cut the suture, flange creation, and tucking the flange under the conjunctiva. And one can see that we can easily further titrate the centration by repeated shortening and repeated flange creation. This technique can also be used with a smaller wound. We can prepare the intraocular lens and the 6-0 proline in a similar fashion, and then load it into a cartridge, and we can insert the intraocular lens into the eye through a smaller wound with the aid of a cartridge. So we now have a well-centered intraocular lens in this patient that started out with a severely phacodonatic white cataract. So in summary, the adjustable flange technique with 6-0 proline has a few advantages. It is very versatile, as seen in earlier videos, and can be used in multiple situations. It is conjunctival sparing. It's technically simpler and faster because of the inherent stiffness of the 6-0. It allows for better control, and you can see that most times we're able to pass the suture through the eye without the use of intraocular forceps. It allows for easy titration and centration by repeated shortening of the suture and flange creation. And most importantly, the thicker suture is more resistant to degradation. However, a word of caution, the flange should always be made not too large to prevent conjunctival erosion. And like with all IOL fixation techniques, proper measurements and markings on the conjunctiva are essential to ensure eventual good centration of the fixation. Thank you very much for your attention, and I'll be happy to take any questions. Thank you.
Thank you very much, John. That was an absolutely brilliant presentation. You make it look very easy, but what should the sort of surgeon who tries this technique for the first or second time watch out for? What's the pitfalls in this technique?
I think this technique does make the surgery easier because it makes passing the suture through the eye more easy to control because of the thicker and stiffer suture. What I would believe is the most crucial part is the flange creation, because when we start, we tend to create the flange a bit too big, and therefore it may not sit flush or within the tunnel, and therefore we're worried about erosion. So the surgeon who starts off should ensure that the flange is properly tucked in under the conjunctiva and the tenons, and watch carefully post-operatively to ensure they're not exposed.
Thank you. I'm sorry, there are lots more questions, but I think we have to move on because we're running short of time, but thank you so much. Our last speaker is, of course, Dr. Ishtiaq Anwar from Bangladesh itself. Ishtiaq, go ahead with your talk on flex.
Cataract surgery has become refractive surgery nowadays, but we want more than 6/6 or N5 from our future cataract surgeries. We want our future cataract surgeries to be perfect and reproducible in every step, and to use less energy and cause less damage to our eyes while removal of the lens fragments. Can femtolaser help us to the future of the cataract surgery, or will it be a costly tool which only a few can use and show to the others? All future cataract surgeries should be like this, that when it is brought to the operation table, the main incision and the side port and the rhexis is already created, and the lens is fragmented into small parts so that we can remove it with very less energy or no energy used at all. And we can enter the eye without using a knife. Like in this case, there was no energy used, and the eye is ready for IOL implantation with a central circular capsulorhexis. Currently, femtolaser is being used in cataract surgeries in steps like creating corneal incision, limbar relaxing incision, capsulorhexis, and nuclear fragmentation. Femtolaser creates an incision which is geometrically and architecturally perfect. And as we have live OCD, 3D visualization is possible, and surgical planning can be to our desired. Once the eye is docked, we can place our main incision, side port incision, LRIs to our desired location, to our desired depth, length, and width. Incision can be made, and this can avoid the imprecise tunnel length or geometry which sometimes we can have in manual incision. And we can have the perfect capsulorhexis, fragmentation of lens, and incision with just press of a foot paddle. Studies have shown the benefit of laser incision like apposition and healing, and we know the importance of incision also has role in postoperative endophthalmitis. We can create limbal relaxing incision in eyes which has less than 1 diopter astigmatism, where we don't use toric IOLs yet. Laser capsulorhexis is something of very beneficial for us. We have all gone through the long learning curve of manual capsulorhexis, and we know the importance of the size, shape, and centration for the effective lens position, which is becoming more and more important nowadays with the aid of multifocal, trifocal lenses. And the size, shape can be reproducible in every case with the laser. There was some issue with the irregular surface of the laser margin with the femtosecond laser, but studies have shown that even if it is not as regular as the manual ones, it has more strength than the manual capsulorhexis is. Laser fragmentation is something which is beautiful in that way that we need very less energy before we start removal of the fragments, because it eliminates the necessity of sculpting or chopping. And there are so many patterns to it that it meets the surgeon's demand. Like we can have a central cylinder, we can have many small cubes, and we can have spiral, which is nowadays used for the posterior polar ones. And just want to share a small video clip of a typical femtocataract. So once the free floating capsulorhexis is removed, all we have to do is separate the nucleus in the already created planes by the laser. And we can see that typical findings that bubble created by the laser is being released once the nuclear fragments are separated. And with all the advancement in the OVD and phaco-dynamics of our latest phaco machines, these sort of cataracts can be removed with very stable anterior chamber, less inflammation, very minimum power used. And I would say that femtolaser cataract surgery especially helps in the complicated cases. Like this one was a very hard cataract with minimum pupillary dilatation, hardly had 5 millimeters dilatation, and the surgery was very easy with the help of the femtolaser. This is a case of an anterior lenticonus, and I had issues with capsulorhexis in the other eye, so I decided to go with femtolaser in this patient, and we can see that in the live OCD how the anterior capsule is bulged forward. So the femto did the capsulorhexis and fragmentation was done, which made very easy for the rest of the surgery. This is the case of subluxation where we can see that there is vitreous in the anterior chamber, and we know how important and how difficult it is for capsulorhexis in this sort of subluxated cataract. The beauty is that we can move the capsulorhexis towards the subluxated area. We have a free floating capsulorhexis. The vitreous was then addressed. Hydrodissection was done and the lens matter was soft in this case. It was removed easily. And then a Sioni ring with one eyelet was introduced in the back. It was centered. The cortical matter was removed. And we had a beautiful central back. I was well implanted in back. But are we there yet? There are some issues like flow of the surgery. It takes around 10 to 15 minutes for a patient to complete this total laser procedure. It's a big machine. It occupies a very part of our operation theater. The cost is very much still now, and there is a lot of human involvement where shows that there is chances of error. And one issue is that after surgery, sometimes the pupil becomes smaller, which suggests that there is prostaglandin released from the anterior chamber. And I just share a couple of my surgeries that did not go as planned with the femtolaser. Here, the LRI was supposed to go on the nasal side, but I overlooked it and it was made temporarily. There was a big study by the European Society of Cataract Surgeons, and it showed that 1 in every 200 surgeries, there was an issue with the capsulorhexis. It was not complete. But in most cases, if we just add the capsulorhexis incomplete part it is complete, but there was instances where there was capsule split and it went to the periphery. And white cataract is something specially that we advocate patients for femtolaser because it prevents Argentinian sign syndrome. But as it shows here, this was not complete. And we had to manually create the capsular rhexis, and we were lucky this time that it did not stent. So in white cataract, rhexis is the only part that we want from femto, but sometimes it is not complete. This was a patient who wanted the latest technology. So she went for laser cataract and was a high myope. I planned a 14 diopter multifocal lens. But when the patient was brought on the table, I saw that the spikes that was supposed to fragment the lens somehow went up and hit the capsules. So there was capsular split in multiple areas. And once it was complete, I could see that I had 3 or 4 cuts which went radially, but I was lucky enough that it did not extend to the posterior and I could implant the desired lens. So there are a lot of benefits of femtolaser, and studies have suggested that the anterior chamber inflammation is less and there is no additional endothelial loss after femtosecond laser. But for future, what I feel that we need the size to be decreased, maybe something attachable below our microscope, and less human involvement, so there is less chance of human error, and we have to reduce the cost so that everybody can afford to have a femtolaser. Thank you all for your patience hearing.
Thank you very much, Ishaq, for the lovely presentation. I think we've overrun a little bit on the time, so we will have to do away with the discussion. But I'd like to thank all my speakers, panelists, the Alcon Academy for sponsoring this, and of course the BSCRS for having us. And if I could have my next slide up, please. And I'd just like to let you know a little bit that our next APACRS webinar is coming up on Thursday, 10th of December on corneal conundrums during COVID-19. Please join us then if you can. Thank you to all of you again, and have a very good night. Take care and stay safe.
Thank you.
Thank you. Thank you very much.